There's one more level up.
Welcome back, everyone. In this episode, we're going to be talking about the peripheral region, which means the parts of the nervous system that are outside of the central nervous system. This includes the peripheral nerves that travel throughout the body and connect the spinal cord and brainstem to the muscles, skin, joints, blood vessels, glands, and visceral structures. Remember, this is all from our textbook, Neuroscience Fundamentals for Rehabilitation by Lundy-Ekman. And this content specifically is from chapter 18. So by the end of this episode, you should be able to connect axon diameter with conduction speed and the kinds of structures those axons innervate, describe the major plexuses, explain why movement is so important for nerve health, recognize sensory, autonomic, motor, and trophic changes that occur with denervation, and compare mononeuropathy, multiple mononeuropathy, and polyneuropathy. We'll also talk about the classic stocking glove pattern of sensory loss and how to distinguish a peripheral lesion from a central nervous system lesion. Okay, let's start with the basics. Peripheral nerves include all the neural structures that are distal to the spinal nerves, as well as the portions of cranial nerve axons that lie outside of the skull. Structurally, peripheral nerves are made of parallel bundles of axons that are surrounded by three layers of connective tissue. The endoneurium separates and supports individual axons. The perineurium surrounds bundles of axons, which are called fascicles. And the epineurium encloses the entire nerve trunk. Arterial branches also enter the nerve trunk, which matters because peripheral nerves depend on a healthy blood supply. This organization is important clinically. When we talk about peripheral nerve injury, we're not only talking about axons. We also have to think about myelin, the connective tissue sheaths, and the vascular supply, because damage to any of these can change nerve function. Peripheral neural structures in the body include receptors such as the muscle spindles, Golgi tendon organs, and receptors in the skin, as well as the motor endings in muscles and the axons themselves. Another important organizational point is that the posterior rami innervate structures along the posterior midline of the body, while the anterior rami supply structures in the anterior and lateral body. Those anterior rami are the ones that go on to form the major nerve plexuses. Peripheral nerves may supply either the viscera or somatic structures. Somatic peripheral nerves are usually mixed nerves, meaning that they contain sensory, autonomic, and motor axons. Cutaneous branches supply the skin and the subcutaneous tissues, while muscular branches supply the muscles, the tendons, and the joints. Peripheral axons are also classified according to diameter and to conduction speed. In general, large diameter and more heavily myelinated axons conduct impulses more quickly than the smaller and unmyelinated axons. The letter classification system, A, B, and C, applies to both afferent and efferent axons, while the Roman numeral system applies only to those afferent axons. The big idea here is simple. Structure influences speed, and speed influences function. Now let's move into the nerve plexuses. The junctions of anterior rami form four major nerve plexuses, and they are the cervical, brachial, lumbar, and sacral plexuses. The cervical plexus provides cutaneous sensory information from the posterior scalp down to the clavicle, and it innervates the anterior neck muscles and the diaphragm. That diaphragm piece is especially important because of the phrenic nerve involvement there. Next, we have the brachial plexus, which innervates the entire upper limb. So when you think of motor and sensory supply to the shoulder, the arm, the forearm, and the hand, you're thinking brachial plexus. The lumbar plexus innervates the skin and muscles of the anterior and medial thigh. And the sacral plexus innervates the posterior thigh and most of the leg and foot. And it also contains parasympathetic axons. So clinically, these plexuses help us understand how symptoms are distributed. If a patient has weakness or sensory changes in a peripheral nerve pattern, the lesion may be distal. If the pattern follows a larger plexus or root distribution, that leads you somewhere else in the differential. I apologize if you hear a 5-year-old boy playing with blocks loudly in the background. That would be Owen. He's my child. All right, now let's talk about something that is easy to overlook, but extremely important. Movement is essential for nerve health. Movement promotes the health of peripheral nerves by improving blood flow throughout the nerve and supporting the movement of axoplasm through the axons. Axoplasm is the intracellular material within the axon, and its movement is necessary for transporting proteins, organelles, and signaling molecules. Normal movement causes axoplasm to thin and to flow more easily, which then facilitates both anterograde transport, meaning transport away from the cell body, and retrograde transport, meaning transport back toward the cell body. This matters because nerves are not static cables. They are living tissues, and they need motion, circulation, and transport to function. Normal stretching and shortening of nerves supports that process. Next, let's move on to the neuromuscular junction. Motor axons synapse with muscle fibers at neuromuscular junctions. And unlike neuron to neuron synapses, no summation of action potentials is required to depolarize that postsynaptic membrane. In a normal motor unit, every depolarization of the motor axon releases enough acetylcholine, or ACH, to trigger action potentials in the muscle fibers that it innervates. Our slides in our textbook also note that the miniature end plate potentials help to prevent muscle atrophy. That sets us up for understanding what happens when peripheral nerves are damaged. So, signs of peripheral nerve damage fall into 3 broad categories, and they are sensory, autonomic, and motor. And importantly, these signs occur in a peripheral nerve distribution. Starting with sensory changes, patients may have decreased or lost sensation. They may also report abnormal sensations, including hyperalgesia, which is an increased pain response, dysesthesia, which is an unpleasant abnormal sensation, paresthesia, such as tingling or pins and needles, and allodynia, where a normal, non-painful stimulus is perceived as painful. Autonomic changes will depend on the pattern of axonal dysfunction. If only a single nerve is affected, the autonomic signs usually appear only if the nerve is completely severed. And in that case, you may see signs like lack of sweating and edema. If many nerves are involved, autonomic dysfunction can be much broader, including difficulty regulating blood pressure, heart rate, sweating, bowel and bladder dysfunction, and sexual function. For motor changes, peripheral nerve damage can cause paresis or paralysis. If a muscle is denervated, EMG recordings show no activity for about 1 week after the injury, and muscle atrophy then progresses rapidly. Muscle fibers begin to develop generalized sensitivity to acetylcholine along the membranes, and fibrillation occurs. But fibrillation is not diagnostic of a specific lesion. Instead, it tells you there's denervation or muscle membrane instability, but not exactly where the lesion is. Then we have trophic changes or trophic changes, which occur when nerve supply is interrupted. The denervated tissues begin to change, and muscles atrophy, skin becomes shiny, nails become brittle, and subcutaneous tissues thicken. Patients may also develop ulceration of the skin and subcutaneous tissues. They have poor healing of wounds and infections, and they might also have neurogenic joint damage. These changes happen secondary to those alterations in blood supply, along with the lack of sensation and lack of movement. At this point, it's going to be helpful for us now to classify different types of neuropathies. Peripheral neuropathy may involve a single nerve, several individual nerves, or many nerves. A mononeuropathy involves a single nerve and is considered a focal dysfunction. A multiple mononeuropathy involves several nerves and is multifocal, meaning that individual nerves are affected asymmetrically. A polyneuropathy involves many nerves and is a generalized disorder that is typically distal and symmetrical. So let's go through these one at a time. With a traumatic injury to a peripheral nerve or mononeuropathy, there are three broad categories based on severity. We have traumatic myelopathy, traumatic axonopathy, and severance. Traumatic myelopathy refers to a loss of myelin that's limited to the site of injury. And a classic cause of this is focal compression of a peripheral nerve, especially repeated mechanical compression. Because myelin is necessary for rapid, efficient conduction, focal demyelination interferes with axonal function. It can cause neuropathic pain, partly because of neuroinflammation and partly because of the ectopic generation of action potentials in nociceptive neurons. In other words, the damaged nerve starts behaving abnormally and can generate pain signals on its own. A classic example of this is carpal tunnel syndrome, which is compression of the median nerve in the space between the carpal bones and the flexor retinaculum. In the late stage of this, patients may have pain, numbness, and decreased or lost sensation in the lateral 3.5 digits and adjacent palm, along with sensory changes in the distal halves of those same digits on the dorsal side. Motor findings can include paresis and atrophy of the thumb intrinsic muscles, especially in the thenar eminence. The diameter of the median nerve is enlarged by about 30% in carpal tunnel syndrome, and that enlargement reflects connective tissue edema, thickening, scarring, and inflammation. Next, we have traumatic axonopathy. In this type of injury, the axons themselves are disrupted. Wallerian degeneration occurs distal to the lesion, and because all axon sizes may be affected, reflexes, somatosensation, and motor function are often significantly reduced or absent. The good news is that regenerating axons can reinnervate appropriate targets because the myelin and the connecting tissue actually remains intact, which gives the sprouts a pathway to follow. Axon regrowth then typically proceeds at a rate of about 1 millimeter per day, which is slow, but it's clinically important when estimating recovery. The most severe form now is severance, where nerves are physically divided by excessive stretching or complete laceration. Here, both axons and connective tissue are completely interrupted, producing immediate loss of sensation or muscle paralysis in the supplied area. If the proximal and the distal nerve stumps are well opposed and scarring doesn't interfere, some axonal sprouts may enter the distal stump and actually find their way back to target tissues. However, in a mixed peripheral nerve, some sprouts may reinnervate with the wrong end organs, which actually limits functional recovery. Now let's shift to multiple mononeuropathy. This pattern affects individual nerves in a random, asymmetrical way, and it involves two or more nerves in different parts of the body. It occurs most often with diabetes or vasculitis when this causes ischemia of the nerves. Because vasculitis can cause this pattern, a patient with suspected vasculitic neuropathy should receive an urgent referral for electrodiagnostic evaluation. Now to polyneuropathy, which is one of the most clinically recognizable patterns. The hallmark features are symmetrical involvement of sensory, motor, and autonomic fibers, often progressing from distal to proximal. The symptoms usually begin in the feet and they later appear in the hands, which creates that classic stocking glove distribution of sensory impairment. And this pattern typically occurs because the longest axons are affected first. Polyneuropathies are not caused by trauma or ischemia. Instead, the causes are often toxic, metabolic, or autoimmune. These common causes include diabetes, nutritional deficiencies secondary to alcoholism, and autoimmune disease. Therapeutic drugs, industrial and agricultural toxins, and other nutritional disorders can also cause polyneuropathy. In diabetic polyneuropathy, both axons and myelin are damaged. Patients may have decreased sensation, pain, paresthesias, and dysesthesias. There's also a loss of autonomic regulation of blood flow, which increases bone reabsorption. Later in the disease, patients may develop muscle weakness and atrophy. It's also important to note that balance and strength training actually are used. They're important here because they reduce fall risk, and exercise improves gait and balance in people with diabetic neuropathy. A major complication is something called Charcot foot, which involves a pathologic fracture, joint dislocation, and if it's untreated, a disabling deformity. That complication reflects how sensory loss, autonomic changes, altered loading, and continued use can combine to damage a foot over time. There's also idiopathic polyneuropathy. In adults over 60 with polyneuropathy, 20 to 30% actually have no identifiable cause. So not every neuropathy can be neatly explained. Another important polyneuropathy we've spoken about before, and that's Guillain-Barré syndrome. In this condition, motor involvement is typically more severe than sensory involvement, and weakness may be worse proximally. The onset is rapid with progressive paralysis, and urgent diagnosis and treatment are essential to prevent respiratory failure because 1/3 of patients actually end up requiring a ventilator. Next, we have hereditary motor and sensory neuropathy, also known as Charcot-Marie-Tooth disease. This usually causes paresis of muscles distal to the knee, and that then leads to foot drop, a steppage gait, frequent tripping, and muscle atrophy. Later, the hands can also become weak and atrophic. Significant numbness is unusual, but patients may have decreased temperature and nociceptive sensation. Therapy then will focus on strengthening, stretching, conditioning, and protection of joints, muscles, and skin. Now, let's briefly separate peripheral nerve disorders from disorders at the neuromuscular junction and from myopathy. And myasthenia gravis, which is that autoimmune disease that damages acetylcholine receptors at the neuromuscular junction. And in that, a classic feature is that repeated muscle use causes increasing weakness, which is why we tend to see that classic eye droop in myasthenia gravis. In botulism, the problem is different. Botulism interferes with the release of acetylcholine from the motor axon. It causes acute progressive weakness with loss of stretch reflexes, but sensation actually remains intact. And therapeutically, botulinum toxin or Botox can be used to weaken overactive muscles, such as in spasticity or dystonia. Myopathy, in contrast, is a disorder intrinsic to the muscle itself. Sensation and autonomic function remain intact because the nervous system is not primarily affected. Coordination, muscle tone, and reflexes are also usually unaffected until muscle atrophy becomes severe enough that muscle activity can't be elicited. So, to sort all of this out clinically, we often use electrodiagnostic studies. Nerve conduction studies and EMG can identify the pathologic location and are often diagnostic. Nerve conduction studies help to differentiate myelinopathy versus axonopathy, upper motor neuron versus lower motor neuron paresis, mononeuropathy versus polyneuropathy, and local conduction block versus Wallerian degeneration. There are also 3 useful clinical signs of polyneuropathy in patients ages 50 and older. If 2 or 3 of these are present, they correlate highly with electrodiagnostic evidence of peripheral neuropathy. These are absence of the ankle jerk reflex despite facilitation, impaired vibration, and impaired position sense of the great toe. During evaluation, patients often report increasing pins and needles as neuropathy because as neuropathy becomes more severe. It is also important to remember that signs of damage can reflect either hypoactivity or hyperactivity of neurons. Most importantly, clinicians must distinguish peripheral neuropathy from central nervous system dysfunction. Peripheral lesions produce signs and symptoms in a peripheral nerve distribution, whereas spinal region lesions produce signs and symptoms in a myotomal or dermotomal distribution. Finally, let's talk about some interventions. Treatment decisions should be guided by sensory testing, manual muscle testing, and electrodiagnostic findings when indicated. Education is essential to prevent complications related to lack of sensation, disuse, or overuse. Patients with sensory loss should be taught to visually inspect the involved areas daily, especially to watch for wounds or redness that persists more than a few minutes. If the feet are involved, proper foot care is critical. For edema, interventions include elevation, compression bandaging, and electrical stimulation. Contractures may be prevented through prolonged stretching or regular daily activities. After a peripheral nerve crush injury, endurance exercise has actually been shown to enhance sensory and motor recovery. In contrast, resistance training or a combination of resistance and endurance training may delay functional recovery, which is an important nuance. Exercises should emphasize gradual strengthening and the functional use of individual muscles and muscle groups. And finally, orthoses are often used to stabilize weight bearing joints, prevent sprains and strains, prevent forefoot drop during a gait in cases of tibialis anterior weakness or paralysis, and prevent deformities related to paresis, paralysis, and lack of sensation. So, to wrap this all up, peripheral nerve lesions produce signs and symptoms in a peripheral nerve distribution. Spinal region lesions, by contrast, show up in myotomal or dermatomal patterns. Normal stretching and shortening of nerves supports blood flow and axoplasmic flow, which helps maintain nerve health. And peripheral nerve lesions may affect one nerve, several nerves asymmetrically, or many nerves symmetrically, giving us the major patterns of mononeuropathy, multiple mononeuropathy, and polyneuropathy. Okay, that's the peripheral nerve region in a nutshell. See you next time. Bye.